Welcome back, focused learners. Today, we're bringing you a brand new explainer that tackles an incredibly complex and, let's be honest, often totally misunderstood topic. We are looking at managing pain and sleep in hypermobile Ehlers-Danlos Syndrome, or hEDS. And we're going to be structuring this entirely around the clinical insights of Dr. Jordan Tishler from his really fascinating chapter in the medical textbook, Disjointed. Basically, we're going to look strictly at the science of medicinal cannabis, strip away all the cultural noise, and see exactly how it functions as a highly specific, targeted medical tool.
Okay, let's dive right into this. For patients living with hEDS, severe, chronic pain is not just some occasional nuisance, right? It is a relentless, everyday reality. And here is the really harsh truth that so many patients face. Traditional medicine frequently just hits a brick wall when trying to treat it. So what do you actually do when the standard playbook of prescriptions just doesn't work?
Well, to answer that, we'll follow a clear clinical roadmap today. First, we'll look at the hEDS pain problem. Second, cannabis for pain control. Third, treating non-restorative sleep. Fourth, cautions and contraindications. And finally, debunking cannabis stigmas.
All right, Section 1, the hEDS pain problem, a clinical necessity.
So patients with HEDs present with a highly complex, multi-systemic condition. And this brilliantly illustrates exactly why standard treatments often fall completely short. Traditional medications, specifically opioids, they frequently yield suboptimal results for HEDs patients. But actually, it's worse than just being ineffective. Opioids can actively trigger mast cell activation, and they significantly slow down your gastrointestinal function. So for an HEDs patient who's already struggling with severe comorbidities like gastroparesis, opioids can literally compound their suffering. And that establishes a very real clinical necessity to find alternative therapies.
40 to 80%. Dr. Tishler notes that when medicinal cannabis is introduced to a patient's regimen, they typically see a 40 to 80% decrease in their need for opioids. And remember, the risk associated with opioids is linear, meaning the more you take, the higher the risk. So right out of the gate, we really have to frame medicinal cannabis as a remarkably powerful harm reduction tool.
Moving on to Section 2, Cannabis for Pain Control, Shifting the Paradigm.
To really understand this, we need to shift our paradigm. We aren't talking about some magical cure that makes the physical source of the pain just vanish. Instead, the crucial point is summarized perfectly by Dr. Tishler. He says, cannabis disconnects the suffering from the pain. Think of pain in two parts, okay? First, there's the objective neurologic signal, your knee is hurting. Second, there's your emotional response to it, the suffering or the degree to which that pain actually bothers you. Cannabis acts on that second element. The knee might still physically hurt, but the emotional distress, the suffering, is essentially divorced from the physical sensation.
But how it's administered matters entirely. You literally have to match the method to the duration of the pain. So for episodic, acute pain, like a sudden migraine, vaporizing the whole flower provides a rapid onset in about 10 to 15 minutes, and it lasts a modest 3 to 4 hours. And just to be super clear here, smoking is never recommended clinically. Now, contrast that with constant, chronic pain. Vaporizing wears off way too fast for that, which creates this terrible yo-yo effect. So for constant pain, edibles or tinctures are used. They have a delayed onset, but they last a solid 8 to 12 hours, providing steady relief when you take them by the clock.
And here is where medical application looks vastly different from recreational use. Clinical application requires consistent, low dosing. We're usually talking in the range of just 5 to 15 milligrams. Pushing beyond that, it doesn't increase relief at all, it just increases unwanted side effects and builds up your tolerance. A true medical patient actually thrives on the lowest effective dose.
Section 3. Treating non-restorative sleep, restoring the autonomic system.
Interestingly, Dr. Tishler finds that cannabis often treats insomnia even better than it treats pain, and it totally avoids those severe morning hangovers or memory issues you get with traditional sleep aids. But to treat it, we have to break sleep disruptions into two distinct categories. Step 1. If your issue is difficulty falling asleep, a small amount of short-acting vaporized flower right before bed is the targeted approach. Step 2. If your issue is waking up in the middle of the night, you need duration. That's where long-acting edibles come in. But because they last 8 to 12 hours, you've got to time them perfectly, taking them early in the evening so they don't overlap with your alarm clock the next morning.
Ultimately, patients consistently report that using cannabis at night is vastly restorative. Now, there is some evidence that cannabis initially suppresses REM sleep, which, sounds pretty counterintuitive since REM is the restorative part, but clinical observations suggest that over weeks and months, the sleep cycle balances itself out, providing that highly restorative rest that hEDS patients absolutely desperately need to manage their daytime fatigue and autonomic instability.
Section 4. Cautions and contraindications, managing the risks.
Look, as with any medical tool, we have to remain totally objective about the risks. So here are the primary cautions. First, cardiac disease. Cannabis can increase heart rate and lower blood pressure, so extreme caution is required for anyone with cardiovascular issues. And for this exact same reason, it should be used cautiously in patients with POTS, which is a very common hEDS comorbidity. Next is age. There are totally valid concerns regarding brain development for patients under 25, so risks versus benefits must be heavily weighed by a care team there. And then there's alcohol. Mixing the two is not a 1 + 1 = 2 scenario. Alcohol actually raises blood cannabinoid levels drastically. It is a 1 + 1 = 8 multiplier. Crazy, right?
And absolutely crucially, driving is strictly off limits. Because the impairment is very real, patients must wait 4 hours after inhalation and a massive 8 to 12 hours after taking edibles. What this means in practice is that a patient's daily driving schedule might entirely dictate the type of treatment they are legally and safely allowed to use.
Finally, Section 5. Debunking cannabis stigmas, myth versus reality.
Now, what's really interesting about this next section is how wildly the medical reality differs from the commercial hype. If you've ever stepped into a dispensary, you've definitely heard about sativa being energizing and indica being sedating. Well, Dr. Tishler points out that this is almost entirely a marketing gimmick. The chemical overlap between these thousands of uniquely named strains is just immense. He uses this great analogy. You might have a preference for a pepperoni pizza over a mushroom pizza, but both will do the job of making you full. From a clinical perspective, you really just need a modest potency strain of about 15 to 20% THC. Those catchy strain names? They don't actually dictate the medical effect at all.
We also really have to reframe this concept of getting high. Society so often views intoxication as a moral failing or just a purely recreational goal. But clinically, intoxication is simply a standard medical side effect. It is really no different than the cognitive fog caused by Benadryl or the alterations caused by prescription opioids. The medical objective is always just to maximize the benefit while minimizing the side effect through precise low dosing.
And then, of course, there is CBD. It is literally everywhere right now, but a true clinical dose looks vastly different than what commercial marketing tells you, 700 to 1400 milligrams. According to the best data we currently have, that is the daily dose required for an average 70-kilogram human to see actual clinical benefit from CBD alone. So those little commercial CBD tinctures you buy at the grocery store where you just take a few drops, they are vastly underdosed and are pretty much primarily relying on the placebo effect.
So, what should you really take away from all this? When it's carefully dosed, when it's matched to the specific type of pain or sleep disruption, and when it's monitored by a medical professional, cannabis is not some fringe alternative. It is a legitimate, structured, and frankly critical harm reduction tool for managing the severe daily reality of hEDS. Which leaves us with a final thought to consider. If the data clearly shows it can safely disconnect suffering from pain and significantly reduce the reliance on highly addictive traditional medications, are we finally ready to move past the societal stigma and treat medicinal cannabis with the exact same clinical objectivity as any other prescription in the pharmacy? Thank you so much for learning with us today on this explainer. Keep asking questions, keep looking at the data, and we'll see you next time.